Welcome to ITLS Chapter 2, Trauma Assessment and Management. This is where you're going to learn about primary surveys and what you need to do to assess your patients and what order you need to take. The objectives today will be to outline the steps needed when you're assessing your trauma patients. You'll need to be able to describe what a primary survey is, explain the need of an initial survey and the differences between the rapid and the focused exam. And we'll also describe when the initial assessment can be interrupted, for what reasons. We'll also talk about critical load and goes and how those should be managed, as well as any life-threatening injuries that are identified during your primary survey, what you should be doing with those. Continuing on, we'll also be able to describe the critical interventions that should take place if they do occur during your primary survey, how to manage them, and then you'll need to know what describing a reassessment exam is, or an ongoing exam, and secondary surveys. So your primary survey consists of these things: your scene size ups, your initial assessment, and your rapid trauma or focus exams. And then you continue on down the algorithm for the reassessment exam and secondary surveys if needed. Primary survey, scene size up. All right, this is when you're going to come into your hazards, number of patients you need, additional resources, mechanism of injury, standard precautions, and you need to verbalize all these things whenever you're in your station making these assessments. Next, remember to delegate to team members. You are the acting team leader during your assessment, so it's important to delegate tasks to members. Even if they're not there, you just need to verbalize that. You can't do it all, so just remember to delegate interventions to other members. Do not stop your assessment unless. So it's very important to remember scene safety and patient safety are priorities, and if any of these four things happen, it becomes unsafe, or the patient has uncontrollable bleed and bleeding to death, airway obstructions, and cardiac arrest, those are all reasons to stop your assessment. Scene size up. In your primary survey, scene size up's one of the most important things that you're going to do, and one of the first things you're going to do. You're going to be identifying any hazards, fires, electrical power lines that are down, how many patients you need, how many ambulances you need, if you need other resources like fire. And this is when you're going to notice your mechanism of injuries as well, to help you make the determination on what kind of help you need, or what kind of care or flight. If you need to fly them out, this is when you'll probably make that determination. Like I said before, hazards, power lines, gas lines, animals, people. You can have some unruly or civil unrest that could cause some issues. You want to verbalize having your PPE and wearing all appropriate PPE. You'll establish how many patients you have. This is a mass casualty incident, or you need extra resources. Are all your resources going to be exhausted, where you have to call in for mutual aid? And then you're going to anticipate the severity by looking at the mechanism of injury. Did the patient go through the windshield? Did they hit the steering wheel? Is there a deformity on the steering wheel? Did they fall out of a tree onto soft ground, onto pavement? All these things you need to take into consideration for your MOI. Next, we'll talk about the initial assessment. This is when you're going to get age, sex, weight, the most important thing is general impression or general appearance. What position are they in? Are they, leaning on their neck, or compromised airways and purposeful movements, and obvious injuries that you can find right off the bat. Skin color is a great one, um, especially in smaller kids. And then you'll move down the algorithm, just identifying any CABCs, so conscious airway, breathing, circulation, or killer bleeds. So identify any of these things in order right away. These are all life-threatening things. Remember, your initial assessment prioritizes and determines the existence of immediately life-threatening conditions. Initial assessment. So like I said before, you get general impression, LOC, and then that's when you're going to apply your manual stabilization and your ABCs. You'll quickly learn how immediate this patient needs to be treated and transported, so make sure you prioritize that patient to the proper level. All decisions on treatment require that you have identified life-threatening conditions first, so make sure you're making that determination. If immediate interventions are needed, delegate them to your team members while you continue your assessment, and that's important during your stations. You're going to have a lot of things running through your mind. Just make sure that you just verbalize them and delegate them. You'll receive credit for it. Rapid trauma survey should be no longer than 2 minutes. All right, it's extremely important that you get very comfortable with doing a rapid trauma survey, and it should become relatively fluid for you over time. This is where critical patients are identified. So make sure that you roll through that in less than 2 minutes. On-scene time for critical patients, it's 5 minutes or less. And it's been like that for a while, and only life-saving procedures should be done. Delegate, like I said, any interventions, and don't interrupt your primary survey unless you have to for one of those 4 reasons given earlier. Reasons to interrupt your primary survey: unsafe scene, airway obstruction or airway compromise, cardiac arrest, and or unable to delegate any of these things, and life-threatening bleeds. So killer bleeds, you stop, you put your tourniquets on, you try to control them. This bleeding to death is now a reversible, treatable threat. Tourniquets, drug pressures, whatever you need to do. Cardiac arrest, obviously, you're going to move to your cardiac arrest algorithm. Airway obstructions, you're going to either alleviate the obstruction or you're going to place an airway if you have to. And if it's unseen safe, your safety and the patient's safety is priority. General impression. This is where you're going to find your immediate life-threatening bleeds, and you're going to take control of those, and then you're also going to get your appropriate age and patient sex and weight, get your general appearance or general impression of the patient, how they're positioned, like I said earlier, if their airways compromised or whatnot, kind of gives you an idea of what happened with the patient. And in their activity, are they making purposeful movements, or are they completely unconscious? And if you have multiples, just remember triage, and those are all delegated treatments. Initial LOC, so cervical spine, manual, you're going to grab manual traction for that first, and if you can delegate off to a collar, that's great. You're going to get your AVPUs on. So when you're going through your alert, verbal, painful, and responsive, make sure you take these things into consideration and what dictates what letter. primary survey. So obviously we're going airway breathing here. Look, listen, feel. Simple positioning suction may be appropriate for these patients whenever you're doing so. Obviously, oxygen is a first-line medication for those. Know your respiratory rates, adult, child, and infant. What's normal, what's abnormal. That should be common. And you should keep those relatively close to you for the exam time, because I believe that's probably something that's going to be covered. Remember major bleeding, circulation, peripheral pulses. Check at your distal areas for pulses. If there is no pulse, if it's too fast, too slow, the quality, the rate, and also identify if the patient is in fact in cardiac arrest. Like I said earlier, skin color and temp is a very good indicator of an emergency for these individuals. So if they're not circulating well, they'll have poor peripherals and poor skin colors. MOIs, mechanism of injury. Is it dangerous, generalized, unconscious? This is where you're going to do your rapid trauma surveys. You see right here they have a spidered windshield, so that could be from a head injury. Right there, does that correlate with what the patient's showing? Do we have a bent steering wheel or airbags deployed? Things of that nature. So if there is a relatively bad mechanism injury, you're going to move directly to your rapid trauma survey. If it's dangerous, and no significant, then we just move to a focused, unless there's a need or a change to move to a rapid trauma survey. If no significant life injury is noted, perform initial assessment and then to your focused. So here you'll see your algorithm for rapid trauma surveys. And just remember their rapid trauma survey is a brief exam done to find all life threats. You're going to learn these skills in your patient assessment later on. So in your rapid trauma survey, you start at the head, move your way down, head, neck, chest, abdomen, pelvis, lower and upper extremities, and back. Okay, and this is pretty rhythmic whenever you go through this. You want to start at the head and neck. You're looking for any major facial injuries, bruising, swelling, penetration, subacute emphysema, neck vein distension, tracheal deviation, condition of neck and breathing circulation, all those things. And you're going to move down, and once you get to the neck, the patient doesn't have a rigid collar on at that time. That's when you would delegate someone to put a seat collar on. So you would be holding manual traction until you get to this point, and then that's when you're going to put that rigid collar on. Go to the chest. Is it asymmetric, contusions, penetrations, paradoxical motions, crepitus? Are there ribs rising with respiration? Is there only diaphragmatic breathing? Look for these signs of blunt trauma and any open wounds as well. Make sure you feel for that tick, that tenderness, instability, and crepitus. Hit your breath sounds while they're here real quick. The chests, are they equal? Are they present? Make sure you're going over that fourth intercostal area and listen to both lines. If there is unequal breath sounds, make sure that we percuss and that we're trying to determine if this patient has a pneumo or hemothorax. Understand what the difference between pneumo and hemothorax is and the differences in sound. Heart tones briefly. Apologies for that, because we're just going to shut that down. Don't spend a lot of time on heart tones. It's just a baseline. If you can hear that and they're muffled, fantastic. If not, move on. Make sure you note any abnormalities in the chest. Flail's chests are a big one. tension and hemopneumos, open chest wounds, and delegate the appropriate intervention for those to one of your colleagues. Abdomen. Once we get to the abdomen, we're going to look for bruising, any DCAT, BLS tick. We're going to gently palpate, tenderness, rigidity, distension, and note any of those issues. Next, we move on to the pelvis. We're going to feel for tenderness, instability, crepitus, all the BTLS tick stuff. Note that tenderness is not the same thing as being unstable. Pelvis may be tender yet stable. So understand that if the pelvis is unstable and you feel a pelvic ring collapse, you can apply pressure, but the pelvis is unstable. Do not check it again. So once you determine that it's unstable, there's no reason to recheck the pelvis. It's not going to get any better. You just need to stabilize those. And you can use pelvic girdles. Some people like to use a sheet when they wrap around the pelvis and tie it in a knot. It's a quick, easy way to make sure that pelvis is stable, especially if you have like open book pelvis. That's a great trick to doing that. Lower and upper extremities, and BTLS tick, all that stuff, motor, sensory. We're looking for distal pulses. We're making sure there's no obvious wounds, and if the patient is conscious, they can move their finger and toes. And then we're going to go ahead and place them on the backboard, and at this time, this is when we're going to check the patient's posterior side. So if the patient has an unstable pelvis or bilateral femur fractures, make sure to use a scoop stretcher in comparison to a long backboard, because we don't want to roll these people onto an injured side. Rapid trauma survey, obviously if a critical situation, transfer the ambulance to complete the exam. It's always best in these cases to get them inside the rig where you have a little bit better controlled environment. All your material is easily accessible, plenty of lighting, and you and your partner can go to work. So we're going to get some vitals. We're going to see if they're altered mental status, if they got. We're going to do a brief neuro exam on these people, nothing entailed. Hit the pupils, make sure they're pearl reactive, what size they are, get a Glasgow scale, and any kind of signs indicating cerebral herniation. So are they having herniation syndrome, possibly any kind of halo testing if needed for cerebral spinal fluid coming out the ears. Make sure during our scan we're looking kind of any medical art tags or anything that's pertinent, and consider any other causes. So here's your GCS scale, obviously. Most of you probably already know how to do this. 4, 5, 6, 15 overall total. Make sure you're selecting the appropriate numbers for how your person's eyes are opening, their verbal response, and their motor response. This is very important to understand that the GCS is not a rapid trauma survey, and it's only done at the end of the survey. So you do your rapid trauma survey numbering first, and then you do your Glasgow afterwards. It's pretty much it's done early in your secondary survey, so it's not anywhere towards the beginning. Priority patients, dangerous mechanisms of injury, and now mechanism of injury dangerous is, I guess, relative to whatever you believe is dangerous. We used to fly people based on mechanism alone, not really do that too much anymore, but nonetheless, there's something to be said about dangerous mechanisms of injury. We want to make sure that we're going to identify those quickly and find out if they're prior or need to load and go, and what kind of care they need to be transported to. So penetrating torso wounds are a big one, gunshot wounds, knife wounds. High-risk groups are obviously your elderly and your children. And then make sure that you note any kind of altered mental status or abnormal breathing or abnormal perfusions. These can be also a key indication of a internal injury, and are a priority patient. These would be your load and goes. Dangerous mechanism, loss of consciousness, difficulty breathing, severe pain, head, neck, chest, torso, high risk groups, altered mental status, difficulty breathing again, abnormal perfusion, and any other abnormality during the initial assessment. So here's your sample history that will be obtained during your exam. This is kind of it's part of your primary survey if you can get it. If not, you can delegate it off and have somebody get that for you. If information must be gathered from bystanders, you can do that. Try to get as much as you can. I know sometimes it's impossible to get these sample histories, but they do help. And like I said before, a more detailed history may be taken later in the secondary survey. You can try to get it earlier, but secondary survey is probably where you're more or less going to end up with it. Load and go situations. Obviously, all these things are load and go. Remember, critical interventions. These are done at the scene, and most of them can be delegated to your team members to perform while you continue your ITLS survey. Obviously, in a perfect world, if you had double medic trucks, you could delegate some of those, but if you have an EMT, sometimes you can't delegate. I mean, in the classroom world, you have all the help you need, so make sure you verbalize delegation. And understand that the patient might be in compensated shock, and you might have some anticipated needs later down the road. They may be compensating currently, but very quickly they will become unstable and they will not be able to compensate anymore. Initiate transport. So make sure that procedures that are not done on scene are not life-threatening. So we don't really need to do splinting and bandaging and all that stuff on scene. We need to make sure that these critical patients are getting those critical interventions on scene. We'll tighten it up a little bit later whenever we're in the rig and we're moving to splint those other non-life-threatening issues. Contact medical direction. Make sure we're calling the hospital as soon as we can. Estimate your time of arrival. Make sure you convey the condition of the patient, any kind of special needs you'll need on arrival. My opinion is that these people need to get to definitive care that's appropriate for them. So if this is, you have to start weighing and thinking about your protocols on what's best for the patient. Is it best to go somewhere close and then fly, or is it best to fly directly? If you have no airways, and obviously you're going to have to stop into the hospital and get an airway before you proceed, but most times than not, if there's a way you can get them to tertiary care center, like over in St. Louis for you guys, for these big traumas, SLU or Barnes or one of those big trauma centers, that's where they need to go. So make sure we're looking for changing conditions on your reassessment exam. These are go through the patient conditions and perform any interventions, or note if there's any changes. Critical patients get reassessed every 5, stable every 15. Remember that. Critical every 5, stable every 15. Each time the patients move, they get reassessed as well, especially if they have an airway, and with each intervention. And obviously they get a reassess if anything changes. These things are all being reassessed. And if there's ever a variation in any of them, they get reassessed again. So your secondary survey. It's more comprehensive than your initial, and it's used to identify all injuries, not just life-threatening. So this is going to be more of a detailed exam here. So this is where you're going to establish a baseline for treatment decisions, and you're going to do, obviously, performed already critical patients, shorter transports, non-criticals you can do on scene. So initial assessment, you're going to repeat vital signs, you're going to repeat your monitoring, take your blood pressures, get all your vitals, run through your breath sounds again, make sure we're keeping a head to toe on our detailed exam. You're going to understand what DCAT BLS tick is. And at the very end, that's when you're going to finish up bandaging and splinting these people. So the bandaging and splinting, unless it's, a killer bleed, bandaging and splinting can wait till the end. Write this down. Burn it into your brain. This is and forever will be part of ITLS. As a new medic student, you should know this. Normal vital sign parameters. This is a great cheat sheet to have. I would suggest having it on your phone. There's a little variation from year to year and from version to version, but for more or less, they're about the same. There's no really reason to memorize the numbers, but you must know about a general age and about a general mean of their vital sign. Adjuncts, pulse oxes, waveform capnography is now the gold standard, and everyone should be using capnography for these patients. Serum lactate, fantastic if you have it, but not a deal breaker. It's great for your septic individuals as well. Portable ultrasounds, man, fast exams. If you can get these are pretty cool. You can find some killer bleeds or some internal bleeding with it. But I wouldn't waste any time on doing it. I would treat your patient and how they're presenting versus trying to root around and find a portable ultrasound device. And it also really depends, I guess, on your service and where you're located in reference to a hospital. MIST. All right, so this is the military and NATO MIST report, which is mechanism, injury, signs and symptoms, and treatments. This is a nice little cheat sheet, which is great. And finally, so we'll just talk about the summary here. ITLS patients, it's key to trauma care. Understand that we have to have this every 3 years. It's not difficult, and the trauma patients are the most fun. I mean, we probably only do, 10% trauma, 90% medical. And but these patients can change quickly. So a lot of this is, algorithms and rhythmic and memorization. So everyone develops a little bit of their own way in doing things. But as students, you need to understand the basics of your patient assessment skills. Biggest thing to do is remain calm. Efficiency versus speed. Make sure you keep the safety of yourself, your team, and your patient at the forefront of all your decisions, and you'll never go wrong. If there's any other questions on this, you can refer them to Karen Eisman at Memorial Hospital. And good luck with your ITLS.